Okay, imagine this for a second. You're in a hospital, right? A place that's all about healing.
Right.
But preventable mistakes, they're actually so common that they're up there with the leading causes of death.
Yeah, it's a pretty stark fact.
It really is. And
Okay.
that's exactly why we're doing this deep dive today into something incredibly important: patient safety and infection prevention in healthcare.
Yeah.
We've got quite a bit of material here. We're looking at everything from, the regulatory agencies, the watchdogs, to the day-to-day stuff that makes a huge difference.
Like hand washing.
Exactly. Hand washing, getting vital signs right. Our mission today is basically to pull out the absolute core knowledge, the main idea, so you can get a real handle on how safety is supposed to work in healthcare.
That's a plan. And
Yeah.
the sources we have, they really give a full picture.
Yeah.
A system that's trying hard to protect patients.
Mm-hmm.
We'll look at the groups setting the standards, the potential dangers lurking in hospitals and clinics,
Uh-huh.
and then really focus on how infections spread and, maybe more importantly, how we stop them.
And we'll also touch on hygiene, right?
Yeah.
And vital signs.
Definitely. Plus the nursing process framework and even how activity or lack of it plays into safety.
And, this isn't just info for doctors and nurses, is it?
Well, not at all. I
Mhm.
mean, whether you work in healthcare or you're a patient yourself, or maybe you're helping a family member through something,
Yeah.
understanding these basics gives you like a much clearer view. It can seem overwhelming, all this info.
It really can.
But we're going to try and cut through that, point out the really essential stuff, the things that make you go, okay, I get it now.
Perfect. Let's jump in then. Patient safety and quality first. The sources really hammer home that the main goals here are, well, protecting patients and always, always trying to get better.
Continuous improvement, yeah. And there's this whole network of agencies working on this.
Right, these regulatory bodies.
And it's interesting. Each one kind of brings a different piece to the puzzle,
Mm-hmm.
like QNCN,
Yeah.
Quality and Safety Education for Nurses. Their focus is making sure nurses have the skills to minimize harm, that the whole system runs smoothly, and that, individual nurses are performing safely.
Got it. And then there's AHRQ.
Yep, the Agency for Healthcare Research and Quality. They're more about taking research and turning it into practical advice, like actual tips to prevent those medical errors we mentioned at the start.
Makes sense. And the Joint Commission TJC, that's a name you hear a lot.
You do. They're a big one. An accrediting body, and they work internationally too. Their National Patient Safety Goals, the NPSGs, those are hugely influential, really seen as the gold standard. They give very specific, concrete steps for hospitals and clinics.
So like a practical checklist for safety.
Pretty much.
Yeah.
And it's always being updated based on, what the current risks are. Meeting these goals isn't optional if you want that TJC accreditation. It shows a real commitment.
And CMS Centers for Medicare and Medicaid Services.
They're pushing for more patient involvement, really encouraging you, the patient, to ask questions, be part of the decisions about your care.
That seems important. Being your own advocate.
Absolutely.
Yeah.
And then you mentioned the National Quality Forum, NQF.
Yeah, that one seemed really significant in the materials.
It is. They work on building agreement across the country on how to measure quality and safety, and they're key in tracking and reporting patient safety events, especially those serious reportable events.
Sometimes called never events, right?
Yeah.
The materials mention these pop up a lot on exams, and that hospitals often don't get paid if one happens.
Exactly. That's a huge financial incentive for prevention, isn't it? It puts a spotlight on errors that just shouldn't ever happen in a healthcare setting. Things that cause serious harm or even death.
Like what kind of things are we talking about?
Well, the sources give some really sobering examples. Discharging a patient who had a cardiac arrest while they were in the hospital, or severe bleeding happening when they're just removing a foreign object during surgery,
Well,
or a patient getting a disability from an electric shock inside the facility. Those are all serious reportable events. But interestingly, something like bruising from bed rails, that's not on the list. Shows you the level of severity they're focused on.
yeah, it really does. And then there are care management events.
Right. That category includes things like, well, the absolute nightmare scenario of a patient abduction, or a death right after surgery, or if a patient wanders off the lopes and gets seriously hurt.
Okay.
And also developing a severe pressure injury, like stage 3 or 4, after being admitted.
These lists are quite specific.
They are. Continuing with serious reportable events. Surgery on the wrong body part, definitely a never event. Hypothermia because the facility was too cold. Or a fall that happened because a patient was given diuretics.
Got it.
But notice, an injury from an assault at the patient's home. not included. It has to be linked to the healthcare setting or care.
Okay.
And for those care management events, discharging an infant to the wrong person, a patient death because of a medication mistake, sexual assault happening within the agency.
Unbelievable.
Yeah. But according to this specific source material, a wrong surgical procedure or a patient suicide within the facility aren't classified under care management events specifically.
Right.
It shows how precise these NQF definitions are.
It really does. It's all about pinpointing those systemic failures within healthcare itself to prevent the absolute worst outcomes. Now, the sources also talked about assessing safety risks in general, and falls came up as a huge one.
Oh, absolutely. Falls are a massive focus area, and they're usually complex, right? It's rarely just one thing. It's often a mix of the patient's condition and the environment around them.
And the consequences can be severe.
Devastating. Leading cause of death and serious injury for certain groups. Lots of agencies provide education on prevention, which involves really looking closely at each patient's risk and putting specific measures in place.
It's not just falls, though, is it? There were other types of accidents mentioned?
Right. You have patient-inherent accidents that could be something unpredictable, like a seizure in someone with epilepsy, or even self-harm. Then procedure-related accidents, which can happen during any medical intervention, surgery, inserting lines, and equipment-related accidents, maybe pull malfunctions, or staff doesn't use a device correctly. A strong safety culture means being aware of all these, training staff, and trying to prevent them proactively.
And it's interesting how risks change depending on age, like the source mentioned for different developmental stages.
Totally. Infants and toddlers, you worry more about falls, choking, things like that. Teenagers, maybe risk-taking behaviors leading to injuries. Older adults face different vulnerabilities due to physical changes, maybe cognitive issues.
So safety plans need to be tailored.
Exactly. You can't apply the same approach to a baby as you would to an 80-year-old. It underlines why individualized care is so critical.
Okay, let's pivot now to infection prevention. Big topic. The material introduces this idea of the chain of infection. Can you break that down for us?
Sure thing. The chain of infection is like the fundamental model for understanding how infections spread. Think of it as a circle or a chain with 6 links. Break any link and you stop the infection.
Okay, link 1.
Link 1 is the infectious agent. This is the actual bug. Could be bacteria, a virus, fungus, parasite, even those weird things called prions. Basically, whatever causes the disease.
Got it. The what? What's next?
Next is the reservoir. This is where the agent hangs out, lives, and multiplies. It could be a person, an animal, an insect, contaminated food or water, even just a surface like a doorknob.
So like its home base.
Exactly.
Wow.
And sometimes microorganisms can live in or on us without causing illness. It's called colonization. They're there, multiplying, but not causing damage yet.
Okay, so the agent's in the reservoir. How does it get out?
That's the portal of exit. The pathway it uses to leave the reservoir. Think blood, spit, mucus, other bodily fluids, feces.
Right. Makes sense. It exits, and then it needs to travel.
Yeah, that's the mode of transmission, how it moves from the reservoir's exit portal to the next person's entry portal. And there are a few ways this happens. Direct transmission is person-to-person physical contact.
Like shaking hands.
Shaking hands, kissing, sometimes fecal-oral route, yeah.
Okay. And indirect?
Indirect transmission uses a go-between. Could be vehicle-borne, so contaminated objects, which we call fomites.
Fomites, okay.
Or things like contaminated water, food, blood products. Or it could be vector-borne, where an insect or animal carries it.
Like a mosquito carrying malaria.
Exactly. That's internal transmission. Or it could be external, like a fly landing on garbage then landing on your food.
Okay, what about droplet and airborne? We hear those a lot.
Right. Droplet transmission involves bigger particles, like from a cough or sneeze. They don't travel very far, usually only about 3 feet or so. Airborne transmission is different. It involves much smaller particles that can float around in the air for longer and travel further distances. Think of tuberculosis or measles.
Okay, so the agent has traveled. Now it needs to get in somewhere.
That's the portal of entry, how the agent gets into the new potential host. Often, it's the same way it got out, like respiratory viruses exiting the mouth nose and entering someone else's mouth nose.
Right. And the last link.
The susceptible host. This is someone who's at risk of actually getting the infection if the agent reaches them.
What makes someone susceptible?
Lots of things. Age is a big one. Very young and very old are often more vulnerable. Your nutritional status, stress levels, if you have other diseases, basically anything that weakens your immune system.
Like being sick already?
Exactly. Or undergoing treatments that suppress immunity. The sources specifically mention older adults, Their immune systems might not be as strong. They often have other health issues, maybe aren't eating well.
And people in hospitals seem particularly at risk.
Definitely. Think about it. Invasive procedures, catheters, ventilators, exposure to lots of different germs, sometimes antibiotic-resistant ones. That's how you get hospital-acquired infections or HAIs.
HAIs, infections, picked up while getting healthcare. That really drives home why breaking that chain is so vital.
Absolutely. At any point you can break it, you reduce the risk.
The materials also mention different types of infections. Localized, systemic.
Yeah, just ways to classify them. Localized means it's stuck in one spot, like an infected cut. Systemic means it's spread throughout the body, like sepsis.
Okay.
Exogenous means the germ came from outside your body. Endogenous means it was actually part of your own normal body flora that got out of whack and caused an infection.
Oh, interesting.
And iatrogenic is a specific type of HAI that's a direct result of a medical procedure or treatment.
It's good to know our bodies fight back, too. The sources mentioned are natural defenses.
Oh yeah, our bodies are amazing. Skin is a huge barrier. We shed skin cells constantly, getting rid of bugs. Saliva has germ-killing stuff. Tears wash things out. Urine flow flushes the urinary tract. All first lines of defense.
But sometimes they're not enough, or they get broken down.
Exactly. Which brings us to asepsis, basically the absence of those disease-causing microorganisms.
And there are two kinds, medical and surgical.
Correct. Medical asepsis is also called clean technique. It's about reducing the number of germs and stopping their spread. Think hand hygiene, using gloves, cleaning surfaces, breaking the chain.
Standard stuff for all patients.
Pretty much. Surgical asepsis, or sterile technique, is way stricter. It aims to eliminate all microorganisms, pathogens, and non-pathogens. Essential for anything invasive, like surgery or inserting certain lines, to prevent introducing germs deep into the body. You have to maintain a sterile field.
Which leads into isolation precautions and PPE, personal protective equipment.
Right, so standard precautions are the baseline. Assume everyone could be infectious. Use hand hygiene gloves, maybe gowns or face shields if there's a splash risk.
Mm-hmm.
Apply to all patients.
Okay.
Then you have transmission-based precautions. These are extra layers used in addition to standard precautions based on how a specific germ spreads.
Like contact precautions.
Yep. For germs spread by touch, usually means gloves and a gown when you go in the room. Then droplet precautions for those larger respiratory droplets, you'd wear a regular surgical mask.
And airborne.
For those tiny particles that hang in the air, that needs a special respirator mask, like an N95, and often a negative pressure room to keep the air contained.
Wow, okay. And a protective environment.
That's kind of the reverse. It's for patients who are extremely vulnerable to infection, like some transplant patients. You use special air filtration, restrict visitors, things like that to protect them from germs.
It's really a system designed to protect everyone. What about when healthcare workers themselves get exposed, like a needle stick?
That's occupational exposure, and it's a serious concern. Facilities must have clear protocols. If you get stuck with a needle or splashed with blood, there are immediate steps to take, reporting procedures, testing for bloodborne pathogens. OSHA has regulations about this too, to keep workers safe.
Okay, that covers infection control foundations. Let's shift to hygiene. Chapter 40. It stresses assessment first.
Absolutely.
Yeah.
You can't just barge in and start washing someone. You need to assess, what does the patient expect? What can they actually do for themselves? What's their developmental stage? Do they use glasses or hearing aids? What are their usual hygiene habits? Any cultural influences?
That's a lot to consider.
It is, but it's key to providing care that's actually helpful and respectful. Based on that assessment, you might identify nursing diagnoses like maybe they have activity intolerance, so bathing is exhausting. Or impaired mobility makes it hard to reach things. Or maybe impaired skin integrity or a risk for infection.
So the plan needs to be personalized.
Totally. Collaborative, if possible. Set goals with the patient. And when you're actually doing the care implementation, the focus is on comfort, reducing anxiety, adapting to what they need and prefer. Plus, it's a great time for education. And keeping their space clean is part of it too.
How does age affect hygiene needs?
Significantly, infant skin is super delicate. So is older adult skin. Foot care is critical for diabetics to prevent complications. How often you need mouth care can vary. Hair care can have big cultural aspects. You need to be gentle, cleaning eyes, ears, nose. For women, perineal care always front to back.
And safety during hygiene is crucial too.
Always. Double check you have the right patient. Clean from cleanest areas to dirtiest to avoid spreading germs. Use good body mechanics so you don't hurt yourself or the patient. And know what tasks you can safely delegate to assistive personnel.
And respecting preferences sounds huge. privacy culture.
Massive. Maintain dignity. Ask about their routines. Maybe they hate morning baths. Work with them. Being culturally sensitive is non-negotiable. And yeah, certain health problems will definitely impact hygiene needs or ability.
The materials also listed specifics like perineal care, different bath types.
Yeah, the nitty-gritty. Proper technique for perineal care. How to do a bed bath, assist with a shower or tub bath. Safe foot and nail care, especially for diabetics. Good oral hygiene, super important for preventing other issues. Hair care, eye care, ear care, even giving a back rub for comfort and circulation, and keeping the patient's environment clean and their bed made properly, it all contributes to well-being.
Let's talk vital signs. Chapter 29 calls them quick indicators of health status.
They really are. Fundamental. Use them for diagnosis, to see how someone's doing, track if treatments are working. Getting that initial baseline reading is so important for comparison later.
What's included?
Usually heart rate, the pulse, respiratory rate, blood pressure, oxygen saturation, SpO2, temperature, and increasingly pain is considered the fifth vital sign.
When should you take them?
On admission, definitely. Before and after surgeries or invasive procedures. Before and after giving meds that could affect vitals, like blood pressure drugs. Anytime the patient's condition seems to change. And of course, as part of routine checks.
And normal ranges vary a lot with age, right?
Hugely. The tables in the sources show specifics for temperature, oral, rectal, axillary, tympanic across ages, from newborns way up. Same for pulse, breathing rate, blood pressure. You need to know what's normal for a toddler versus a teenager versus an adult.
And terms like bradycardia, tachycardia.
Yeah, slow heart rate, fast heart rate, different stages of high blood pressure, low blood pressure, it's all defined. And a key point, delegating vital signs to, say, a nursing assistant. Only okay if the patient is stable. If they're unstable or complex, the nurse needs to do it.
Understanding those age norms is crucial then.
Absolutely fundamental. A pulse of 130 might be fine for a baby, but it's a big red flag in an adult. The source material also touches on the physiology, like the hypothalamus in the brain controlling temperature. Body temp is basically heat produced minus heat lost.
Core versus surface temp.
Right. Core temp is the most accurate measured inside, like pulmonary artery, bladder, rectum, ear. Surface temps like oral, armpit, forehead are easier but less precise, more affected by the environment.
And lots of things affect temperature.
Oh yeah. Blood flow, room temp, body's ways of warming up or cooling down, shivering, sweating, blood vessels constricting or dilating.
Yeah.
And then there are alterations like fever, heat stroke, heat exhaustion, hypothermia, frostbite.
Okay, pulse.
That's the wave of blood you feel in an artery. Gives you an idea of circulation, lots of places to feel it: wrist, neck, behind the knee, foot. You check the rate, the rhythm, is it regular, the strength, and if it feels the same on both sides.
Desperations.
That's breathing gas exchange.
Huh.
You count the rate, breaths per minute, check the depth, shallow, deep, and the rhythm, regular or irregular. There are specific abnormal patterns too, like Cheyne-Stokes or Kussmaul's, that can signal serious problems.
Blood pressure.
Force of blood against artery walls. Systolic is the peak pressure when the heart contracts. Diastolic is the pressure when it relaxes. Depends on how much blood the heart pumps and how resistant the vessels are. Blood volume, thickness, artery elasticity all play a role.
And errors can happen when measuring it.
For sure. Using the wrong cuff size is a classic one. The materials mentioned: Korotkov sounds, the series. Those are the thumps you listen for with the stethoscope. And definitions for hypertension and hypotension are there too, with risks and symptoms.
Oxygen saturation, SpO2.
Usually measured with that little clip on the finger, the pulse oximeter. Tells you the percentage of oxygen carried by your red blood cells. Pretty reliable, but things like nail polish or poor circulation can mess up the reading. Need to know normal values, usually above 95%. Sometimes you need to use an earlobe or forehead sensor instead. And capnography measures CO2 and exhale breath, another tool.
And pain, the fifth vital sign.
Very crucial. Needs regular assessment using scales. The patient understands numbers, faces, whatever works. Can't just ignore it.
How do you prioritize which vital sign to check first if someone's crashing?
ABCs. Always. Airway, breathing, circulation. That guides your immediate assessment. The material also mentions orthostatic hypotension, that drop in blood pressure when you stand up suddenly.
Right, dizziness.
Exactly. And finally, it just reminds us that lots of factors affect all these vital signs: time of day, exercise, stress, illness. Temperature, for instance, is usually lowest in the wee hours of the morning, highest in the late afternoon.
It really shows how dynamic they are. Okay, connecting all this is the nursing process.
Yeah, the sources frame it as the underlying structure for safe, effective care. ADPIE assessment, diagnosis, planning, implementation, evaluation. It's the thinking process nurses use.
Assessment is gathering info.
Right. Objective data, what you see, measure, like vital signs. subjective data, what the patient tells you. Then diagnosis isn't medical diagnosis, but a nursing one, identifying the patient's response to a health problem, like impaired mobility or risk for infection.
Planning is setting goals.
Yep. SMART goals, specific, measurable, achievable, relevant, time-bound, and figuring out the interventions. What are you going to do? Some things nurses do independently, others need a doctor's order.
Implementation is doing it.
Putting the plan into action, prioritizing, maybe using Maslow's hierarchy, safely delegating tasks if appropriate, using clinical practice guidelines, those evidence-based recommendations.
And evaluation.
Checking if it worked. Did the patient meet the goals? Do we need to change the plan? It's ongoing. It ties everything together: safety, infection control, hygiene, vitals, into a logical flow.
The materials also touched on activity and exercise versus deconditioning.
Big difference. Activity has tons of benefits, physically and mentally. Proper body alignment, mobility, all good. Inactivity, deconditioning leads to problems.
What influences activity levels?
Lots of things. Age, health status, physical and mental. Lifestyle choices, attitude towards exercise, how tired or stressed someone is, even the environment or resources available. Assessing activity tolerance, how much someone can actually do, is important.
And helping patients move safely is key.
Absolutely. Preventing falls, teaching how to use walkers or crutches correctly, safe transfer techniques, it's all covered under safety guidelines for nursing skills.
Then the flip side, immobility. What are the big risks there?
Oh, immobility is rough on the body. Affects everything. Lungs, risk of pneumonia, atelectasis, lung collapse. Heart and circulation blood clots like DVT, orthostatic hypotension. Muscles waste away, disuse atrophy. Skin breakdown pressure injuries. Bowels get sluggish. Urinary problems, even affects mood and mental state. Prevention is huge.
How do you prevent those things?
Range of motion exercises are key, keeping joints moving, even if it's passive ROM where the nurse moves the patient's limbs. Managing risks for DVT, maybe compression stockings or medication. Getting patients up carefully to avoid orthostatic drops. Encouraging deep breathing for lungs. Turning and repositioning constantly for skin.
Positioning is important, though.
Crucial. Different positions: lying flat, supine, on the stomach prone, side lying lateral, Fowlers, sitting up. They all serve different purposes for comfort, breathing, circulation, preventing skin issues and contractures. Table 39-2 in the source shows these.
And nurses need to protect themselves, too.
Definitely. Proper body mechanics, using your legs, keeping your back straight, asking for help, are essential to avoid injury when moving and lifting patients.
Okay, we've covered a lot of ground. If you had to boil it down, what are the absolute core takeaways from this deep dive?
I think the main thing is seeing how interconnected it all is. You know, patient safety isn't just one thing, it's the big goal. And infection prevention, good hygiene, accurate vital signs, those are all essential tools or strategies to get there.
Right. They all support that main goal.
Exactly. Understanding who the regulatory bodies are, knowing the common risks like falls or HAIs, grasping that chain of infection so you know where to intervene, sticking to aseptic principles, it all builds towards safer care. And the nursing process is the framework that helps put it all together for each individual patient.
It's a complex system. Thinking about modern healthcare, what do you see as maybe one of the biggest ongoing challenges in keeping patients consistently safe?
That's a tough one. There are many, but I'd probably say communication and teamwork, effective collaboration, making sure information flows smoothly between everyone involved: doctors, nurses, pharmacists, therapists, the patient, the family.
Yeah, breakdowns there seem common.
They can be. When communication fails or people aren't working together seamlessly, gaps can open up. And that's often where errors happen, even if you have great protocols on paper. So fostering that culture of open communication and true teamwork is, I think, a huge ongoing challenge.
That's a really great point. Well, hopefully this deep dive has given you, our listeners, some valuable insights. If anything we talked about really grabbed your attention.
Yeah, dig deeper.
Exactly. Look up the latest national patient safety goals from the Joint Commission. Read more about specific isolation precautions, or maybe explore how different vital sign patterns can indicate certain conditions.
The more you understand, the better equipped you are, whether you're giving care or receiving it.